You know, anemia is not a disease in and of itself. It's a sign of another disease. And so sometimes that can be something as straightforward as a drop in the renal function, a drop in the glomerular filtration rate because of aging or because of complications of hypertension or diabetes. But sometimes it can be a sign of something much more serious, a primary bone marrow problem, a hematologic malignancy, or some sort of immunologic dysregulation. So it's important, I think, when one sees patients with anemia, not to blow it off, not to ignore it, because it can be explained in almost all cases, and it is usually a sign of a condition that may at least need to be tracked, if not actively diagnosed and treated.
So in a male, let's say, and their hemoglobin is 12.8 or something, just a little bit anemic, or is that something I can kind of watch for a while, or should I be working that up, or, you know?
Well, that should be, even though it's quite mild, that should be a sign of some concern because it's not normal. And there are even a couple of large prospective studies that have shown that people who have hemoglobins that are in the normal range, but at the very lowest sort of quintile of the normal range, 13.1 or so, have a higher mortality following them prospectively, all-cause mortality, compared with those who have a hemoglobin of 14 or 15. And then, of course, if you get a very high hemoglobin in the 17, 18, then the mortality begins to go up again. Many of those patients are smokers or have COPD, or there's a few with polycythemia in there, and so it's clearly a J-shaped curve. So even I think somebody with mild anemia, that may be a sign of something as important to find as a colorectal cancer. One of the most common causes of anemia in an adult male is gastrointestinal bleeding, including polyps or carcinoma of the colon and rectum. So it's important not to ignore that. I think that behooves an evaluation. Now, how one goes about that evaluation is very much, I think, determined by two things. One, the severity of the anemia. Certainly somebody whose hemoglobin is 8.5 is someone who needs a much more urgent evaluation than this patient that you just described, Ryan, who has a hemoglobin of 12.8. That patient certainly needs to be evaluated, but they don't need an ER visit or an urgent endoscopy. The other thing that's very helpful is the MCV, the mean cell volume, because patients who have a low MCV have a different differential diagnosis than those who have a high MCV or a normal MCV. And although there can be some overlap with the low MCV, we're thinking about things like iron deficiency, we're thinking about thalassemia, we're thinking about chronic inflammation. With a high MCV, we're thinking about B12 and folate deficiency, we're thinking about alcohol or medication effect, and we're thinking about a primary bone marrow disease. With a normal MCV, it's all over the map. A lot of those are anemia of chronic disease, chronic inflammation. There are some people with a normal MCV who have a combined deficiency. They've got B12 deficiency, so they have macrocytosis from that, but they've also got iron deficiency, so they have microcytosis, and it balances out, so they have an average mean cell volume. So that is a much more varied, a much more heterogeneous group. That's where the renal failure patients fit in, is in that normal MCV group. But that can be quite a helpful tool for the initial evaluation. If a primary care doctor were to evaluate a patient who had a high MCV, the thing that should be done is to assess a B12 and folate level and try to sort out through the history, is the patient using alcohol heavily or on a medication.
That can be, alcohol can cause a high MCV in the absence of dietary deficiencies.
It can do. Alcohol alone can do that. It has an effect on the red blood cell production such that it can cause a macrocytosis or even a macrocytic anemia all by itself, even without bleeding, even without dietary deficiency. If it's not one of those things, though, then that's a patient who probably should see a hematologist because the likelihood of needing a bone marrow exam is quite high.
So before we go there, let me just ask you about there seems like there's new testing for the B12, which used to be sort of cut and dry, but now what the bottom level is and what is sort of the end of the bottom. So where do tests like methylmalonic acid and other tests fit into that? And also with folate, aren't there some more sophisticated tests than just doing the checking the folate on the request form?
Right, right. So that's a good question. So B12 folates that are reported, B12 levels that are reported as normal by the lab overlap with the levels at which true tissue level B12 deficiency is present. And so for a patient who has a B12 level of 280 or 312 or below 400, even though that may be reported as normal, the patient may actually have B12 deficiency. And that's an easy thing to test for. You just order a methylmalonic acid of either urine or serum, and if it's high, then the patient probably has tissue level B12 deficiency. For folate deficiency, it's better to measure a red cell folate if you can, rather than serum folate, because serum folate can change quite quickly, even with one good meal that has some vegetables in it. So the classic case is the alcoholic patient who's hospitalized and the folate is not drawn until the guy's been given his supper, and the supper had some vegetables and he hadn't eaten that in weeks, and so there's a spurious transient elevation of the serum folate. But if you were to measure the red cell folate, that would be low in such a patient. So the homocysteine also can be a marker of folate deficiency, but homocysteine is sensitive to a number of other influences. Homocysteine can be elevated in patients who have B12 deficiency, B6 deficiency, patients who have a polymorphism in a gene called MTHFR, methyl tetrahydrofolate reductase, and there are other genes involved in methionine metabolism that can elevate the homocysteine level. So it is, although it's a risk factor for cardiovascular events, a high homocysteine, it's not as simple as high homocysteine equals folate deficiency, whereas high methylmalonic acid equals B12 deficiency, and those patients should be repleted.
So if the patient doesn't have a history of alcoholism, there's not any obscure diseases causing their macrocytic anemia, their B12 and folate, it's not nutritional, and the MCV is good, and let's say we've done iron studies, those are in the normal range, is that the time that I should be calling in hematologist?
That is the time. The only other thing I would do in that patient is just to make sure a blood smear has been done, because occasionally there'll be artifacts like red cell clumping that elevate the MCV but aren't true macrocytosis. So if a patient, for instance, has a monoclonal protein, MUGUS, a paraproteinemia, or if the patient has recently gotten over a mycoplasma infection, there can be some rouleau formation in the case of the monoclonal protein, or red cell agglutination. And when those cells go through 2 or 3 at a time through the counter, then it can artifactually elevate the MCV. So if you do a peripheral smear, then you'll see whether there are true macrocytes or not. So that would be the other thing I would do before sending the patient to the hematologist.
And when they arrive at your office, is it a bone marrow biopsy? Is going to likely be, if not the first step, the second step? How's that, and what are you going to be looking for? Am I right on that?
Yeah, so if those other things have been ruled out and there's not an obvious cause, then typically I would do a bone marrow biopsy to evaluate what the status of the marrow is, what the cell morphology looks like, what the chromosomes look like in the bone marrow, because that patient's at quite a high risk for myelodysplasia. There was a recent paper by a group from Toronto that looked for, in patients with anemia, what predicted MDS. And there were four factors that came to the forefront. One was, age over 60. The second was an MCV over 96. The third was a high LDH. And the fourth, which was a little weaker, was a elevated red cell distribution width, or RDW, which the RDW is just a marker for how varied the red cells are, how what the distribution of their sizes is. And so a high RDW usually signifies that there's some sort of production problem, that either the patient's iron deficient, so uneven amounts of iron and hemoglobin are getting incorporated into the different cells and their different sizes, or the patient has a primary marrow failure problem, so the marrow's just churning out different clones of cells with different morphology. So those features would suggest an MDS.
Now, MDS, and and maybe I'm getting into a more complicated question than I want to, but is that a blood cancer? Isn't it a blood cancer?
It's sort of in the shadowlands between some of the more benign conditions and a malignancy. It is a clonal disorder of blood cells, so not everything that's clonal is a true malignancy. I mean, colon polyps are clonal. A monoclonal gammopathy of undetermined significance is clonal, but these have a very indolent natural history, and they're not, invasive and things. So clonality is not equal to malignancy, but clonality is required for malignancy, and there's great variety in the prognosis for MDS. The very highest risk patients have a median life expectancy that's only a few months, and so certainly that is behaving like a leukemia, like a malignancy.
All right. So you find you do the biopsy, you get the chromosomal markers in the pathology that suggest MDS, and what can you do, and what should I be looking at? Is there things that I should be thinking about as a primary care doctor to coordinate with you that I got to be thinking about? I'm thinking about, are there certain immunizations, infection prophylaxis, things that I should be thinking about, like are these patients immunosuppressed? Is there things that I should be knowing about?
It's a good question. So it is certainly a partnership between the hematologist, oncologist, and the primary care doctor, because most of these patients are elderly and have a number of comorbid conditions and are going to be seeing multiple physicians for management of these. There are certainly treatments for myelodysplasia. Most of them are, other than stem cell transplant, are pretty mild intensity and can be given even to elderly patients with relative safety. But these patients are at increased risk for infection. Infection is the #1 cause of death in MDS, and infection, even fatal infections, can happen with a neutrophil count of 1,200 or 1,400 because the neutrophils are also defective. So this is the kind of patient that if a primary care doctor got a call and the patient had a fever of 102 or such, that patient probably should, be evaluated pretty promptly and be started on antibiotics, whereas, your otherwise healthy person who had just a fever, you wouldn't immediately rush in and, give them a quinolone or something. Mm-hmm. But a patient with MDS is more vulnerable. For immunizations, they should have their up-to-date immunizations. There's not anything special. These patients rarely have hyposplenism or any of the things that trigger supplemental vaccinations, but they certainly should have age-appropriate pneumovax. They should have the influenza vaccine. And I think the other thing that I would state is that patients with MDS, because of the anemia, there's often a lot of stress on their cardiovascular system, and so optimal medical management of coronary artery disease, hypertension can help them be symptomatic at a lower level of hemoglobin, so that somebody who is on a long-acting nitrate may tolerate a hematocrit of 27, but if they weren't on that nitrate, they would be quite symptomatic at that level.
Well, let me ask you about this. What about the antiplatelet drugs, I'm thinking starting from aspirin and going on,
Right.
how safe are those to use with these patients?
So that's a great question. Aspirin, baby aspirin, in somebody whose platelets are not defective, you can use even down to a platelet count in the 30 to 50 range. Usually we say if the platelet count gets below 30, all anticoagulants should be stopped unless it's a special circumstance. And full dose aspirin usually not if the platelets are down below 70. And certainly Plavix and things, the platelets should be above 50 to 70 to use those. Myelodysplasia is a little bit more challenging because the platelets are, again, often dysfunctional in addition to being reduced in number. And so there are some patients who have platelets that are no good and will bleed even at a relatively modest degree of thrombocytopenia. For instance, I have some patients who have recurrent bleeding even when their platelet count is in the 60s and 70s. And they, if you look at their platelets on a blood smear, they don't look normal. I mean, they've got no granules, and they're big, and they're probably, even though they're counted as platelets by the machine, they're not any use for the patient. So that makes it a little bit harder to make a blanket recommendation about anticoagulation in patients with MDS. Most of the time it is safe, and most patients will tolerate aspirin down to a platelet count of 30, but there are some who won't.
So, at the ASH meeting, was there anything in particular in terms of looking at your area of research, MDS and anemia, that you think would be important that's new for the family doc or the other primary care provider to know about?
Well, I would say that this ASH meeting has had a couple of major themes, and one of them is that we are really seeing now the fruits of all of the massive genome sequencing projects that are going on. So lots of different diseases, new mutations are being described. And that's true of myelodysplastic syndrome as well. There's a class of mutations now that there's more than 8 different genes involving various components of RNA splicing. If you remember from basic molecular biology, the exons get knit together and the introns get cut out, and that process requires a big multi-protein component complex called the spliceosome. And in the last couple of months, there's been a New England Journal paper and a Nature paper, and there's about 10 abstracts here at the ASH annual meeting describing that most patients with MDS associated with ring sideroblasts and a number of other diseases as well at a lower level have mutations in components of this spliceosome, including CLL is the other fairly common one, but a number of solid tumors. And that's just one example. I mean, there's follow-up data on the striking finding that every patient with hairy cell leukemia has a mutation in BRAF, a V600 mutation, and that has immediate implications.
BRAF?
Right.
Now, what is BRAF?
Oh, it's one of the signaling molecules. So it acts as an oncogene when it's activated by this mutation.
So it's pro-proliferation, anti-apoptosis.
And it is a mutation that's found in a number of different solid tumors and lung cancers and head and neck cancers and things. So it was quite surprising to find it. I don't know if there's any other example other than CML, chronic myeloid leukemia, where there's a mutation that's present in 100% of cases, but that seems to be
well, certainly gives you an exciting target to be looking at, when you have one pathway,
And unfortunately, that's a disease for which we already have excellent treatments. I mean, cladribine, 2-CDA, puts almost every patient in a very long remission and cures many. So, but there are other examples as well. LGL leukemia, large granular lymphocyte leukemia, which is a chronic lymphoproliferative disorder that's fairly common, is most of those patients, it looks like, have STAT pathway mutations. And this is, again, downstream of JAK2, which many people may have heard of, which is mutated in most cases of polycythemia vera. So to have STAT3 mutations and other mutations in the pathway in these large granular lymphocyte disorders is interesting. LGOs there's a connection with rheumatoid arthritis, and many of the patients with Felty syndrome, which is an association of RA and neutropenia and splenomegaly, have large granular lymphocytes in the blood.
So if I'm understanding the promise of the sort of molecular, understanding the human genome and breaking this down not just for the healthy human, but looking at each subgroup is actually starting to bear fruit. We're learning pathways, and then we're able to make molecules that either inhibit those pathways or antibodies against certain pathways, or that this is actually starting to be translated from the bench into clinical trials and actual medications.
Correct, and it is a tremendously exciting time from that standpoint. I think one of the things that we're learning is, again, cancers are pretty smart in that they've often got redundant pathways, and so there may be several different oncogenic pathways that are activated, that are mutated. So, in an individual patient, it may be difficult to figure out which of those we need to actually inhibit to put the disease into a durable and complete remission. CML, which is the sort of poster child for molecularly targeted therapy, is a relatively stupid cancer in that it's dependent in just about every case only on the BCR-ABL. And so if you successfully inhibit that, then the disease goes in remission. Most of the other common malignancies, whether that be hematologic or solid tumors, have 8, 10 mutations or more, and probably a large subset of those are actually fairly critical for the behavior of the disease.
Any final thoughts or reflections on ASH 2011 that you think would be important for primary care?
I think it is a very exciting time in terms of the new advances, the new discoveries that are being made. But I think that the flip side of that is we still have a great deal of difficulty applying what we already know and putting that into practice, whether that's because of resource constraints or logistics and practices. And so, many of the many of the screening guidelines are not adhered to fully because of different limitations, and many patients, because their insurers won't pay for certain types of evaluation, can't get something like anemia properly evaluated without a lot of hassle for the patient and the doctor. So I think that is one of the things that I'm always struck by when I come to ASH is there's so much fascinating data and all these new drugs and molecular targets, and really understanding the biology of the disease. And then when I go back to the clinic, we're still fighting with the insurers every day, and the patients are lost to follow up, and it's
welcome to my world.
There's such a disconnect between what goes on at a meeting like this and then what happens in our clinics from day to day, and we've got to find ways to bridge that gap.
Well, thanks very much. I think this is very exciting. The promise of what's here. It's still mostly a promise,
right,
but it's an exciting promise that we can be moving away from some of the more traditional toxic cocktails to more targeted therapies as we increase our understanding about what's going on at the molecular level.
Yeah.
Thanks so much.
Thanks, Brian,
Thanks.
for talking with me
Thanks.
today.